Welcome to the Driving Quality Navigating Healthcare with Leading Age Illinois and Iowa as we discuss the long and short stay vaccine quality measures. I'm Kelly Van Reed, the Director of Clinical Services with Leading Age Illinois and Iowa, and I'm joined today by my colleague Sam Heibel. Sam, would you like to welcome our guest today?
Sure. Hi, everyone. My name is Sam Heibel, and I'm Director of Advocacy and Engagement with Leading Age Illinois and Iowa. I do everything from government relations to member engagement. And I'm going to turn it back over to Kelly to help get us started.
Thanks, Sam. So as I said earlier, we are going to cover both the long and short stay quality measures related to influenza and pneumococcal vaccinations for residents, along with who is included in which numerators and denominators, what exclusions exist for these measures, the best practices for the highest percentages, and then touch on employee vaccines, as well as other vaccines that are not included in these specific measures, but you may have to report on.
The federal government has kept us on our toes with recent vaccination guidance. I'm not quite sure how Kelly keeps everything straight with all of the activity, but she has been a great resource for our members to identify who should receive what vaccine and when, along with where different recommendations may have different implications. With all that being said, Kelly, I'm going to turn it back to you to tell us about influenza vaccines.
Yes, so the government has been very difficult as it is related to vaccinations. So we'll talk through what is included and what you need to be doing with these so that you understand what the guidance is. So with both influenza and pneumococcal vaccinations, the short and long stay quality measures are very similar, with only the denominators being different between the short and long stay. But there are some differences between the different vaccines. So first, let's talk about influenza. So the short stay influenza vaccine measures the percentage of short stay residents, which is defined as 100 days or less, who are assessed and appropriately given the influenza vaccination during the most recent influenza season. So for reference, the influenza season for CMS purposes is October 1st through March 31st annually. The numerator for this measure includes coding under two different item sets, which is O0250A equals 1 or 2 when the resident was assessed and received the influenza vaccine, either 1 inside the nursing home or 2 outside of the nursing home, or O0250C is coded as 3, which means the resident was offered the vaccine and declined it. Or 4, the resident is ineligible to receive the influenza vaccine due to medical contraindications. As you will note in a couple of slides, the medical contraindications for the influenza vaccine include that the resident had an anaphylactic reaction to eggs or other components of the vaccine. They have a history of Guillain-Barré syndrome within 6 weeks of receiving a previous vaccine, or they had a bone marrow transplant within the last 6 months. For the denominator, the short stay measure includes all residents with an entry date of A1600 on or before March 31st of the most recent influenza season and had at least one ARD on or after October 1st through June 30th and discharged from the nursing home within 100 days. So as you'll note on this slide, the long stay influenza vaccine measure is very similar to the short stay measure. However, in the denominator, they include the long stay residents who resided in the nursing home 101 days or more. So those are your long stay residents. The only exclusions for this measure are residents with a target assessment date that is 179 days or less in age, so they're less than 6 months old, as the influenza vaccine is not recommended for those individuals, and they likely won't be included in your nursing home population anyways. On this slide, I included the medical contraindications that are included in the quality measure user's guide, which we talked about a few moments ago. There may be others, but if you are coding a medical contraindication to the vaccine, you'll want to make sure that you have supporting documentation as to why the vaccine was clinically contraindicated in case you are audited on your MDS coding. I also included a note on the measure that it is calculated over a 12-month period, but the residents must be in the nursing home at least one day during the influenza season. So, for example, if the resident resided in the nursing home from July 1st until August 30th and then was discharged home, they would be included in the 12-month period. However, since they were not in the nursing home during the influenza season, and lacked an MDS from 10/1 to 3/31, they will not be included in your measure numerator or denominator. Additionally, when you pull your quality measure reports from iKeys, you may note that each category is individually listed. So, for example, the report will have four numbers: what the public sees, which is the percentage of residents that have the influenza vaccine, declined the vaccine, or had medical contraindications to the vaccine, as well as these numbers individually listed: the percentage of residents who received the vaccine in one measure, who declined the vaccine in another measure, as well as the number of residents that had medical contraindications coded. These numbers will not be posted on the public-facing website, but are available for you to review within your report.
Thanks, Kelly. That's a really clear breakdown of how the influenza vaccine measures are structured for both short and long stay residents. I appreciate the reminder about ensuring documentation supports any medical contraindications, especially since those details can get scrutinized in audits. The clarification about the reporting periods and how residents are counted in the numerator and denominator is also really helpful.
Yeah, I'm glad that it was clear as mud because those dates and coding are complicated sometimes. So next, let's talk about pneumococcal vaccinations. Similar to influenza vaccines, the only difference between the short and long stay measures are the residents included in the denominator. So for short stay residents, the numerator includes the number of residents who had a pneumococcal vaccine that is up to date, or O0300 on the MDS A is coded as 1, or they were offered the vaccine and declined it, or O0300B is 1, or they were ineligible due to medical contraindications, O0300B equals 2. In the denominator for short stay, it again only includes residents in the nursing home for 100 days or less. So here you'll see the long stay measure, which includes the same three item sets, and the denominator, which includes residents that were in the nursing home for more than 100 days. The only exclusions include when a resident has an age that is less than 5 years old on the target assessment, as the pneumonia vaccine is not recommended for these individuals. Again, they're not likely to be within your population. And additionally, you will note that medical contraindications are slightly different from influenza, and include any kind of anaphylactic hypersensitivity to the components of the vaccine, that they've received a bone marrow transplant within the last 12 months, or they've received chemotherapy within the last 2 weeks. Again, with this measure, you'll be able to see the response on the MDS separately, including the percentage that are up to date, the percent that were offered and declined, and the percent that didn't receive the vaccine due to medical contraindications. Those measures, again, are not posted publicly, but available in your report.
Now that we know how these measures are calculated, can you tell us what best practices are to ensure that you ace this quality measure?
Yes, so this may be one of the easiest quality measures to work on. So first, you'll want to ensure that you have higher numbers on these measures. So ideally 100%, because that means you've either given all of the residents their vaccines that they've consented to, you've offered and they've declined to have the vaccine, or you are unable to give them due to a medical contraindication. There are a lot of strong opinions right now about vaccinations, so you may run into problems where the resident just does not want a vaccine, regardless of any efforts you make to convince them. So on this measure, I included some best practices based on what the regulations require at F883. So first, when you admit someone, you should assess their vaccination status right away. So this may include asking them if they've received the influenza, pneumococcal, and COVID-19 vaccines and where those were. You may also be able to locate this information on the vaccine registry within your state. Since it may take you a little time to locate that information, if the person has or hasn't received the vaccine, my recommendation would be to have the individual decide if they want the vaccine if they're not current on their status. This way you can get that consent signed while you're already having the family member or the resident present and they are signing other paperwork. And this will allow you to administer the vaccine if they're not up to date without needing to then track down the resident or their alternate decision maker again to educate them and get a consent or declination of the vaccine. You also can place a to-do on your calendar for the first couple of days of admission, so you can account for this within your admission or 5-day PPS MDS look back period. If the resident has not received the vaccine, then you can administer it. Depending on your individual policy and practices, you may want to wait because if the resident is under a skilled stay and you administer the vaccine, it would be included in consolidated billing. Whereas if you wait to administer the vaccine under a Medicare B private pay or Medicaid stay, the vaccine would then alternately be paid for under one of those services. But don't forget to give the vaccine once that skilled stay has ended. I've also included what up to date means as of early October 2025 for both influenza and pneumococcal vaccines. While influenza is pretty clear, pneumococcal vaccines are not as cut and dry. So in surveys, you will occasionally see the F883 cited because the nursing home saw that the resident had one dose of a pneumonia vaccine and was considered up to date. But in actuality, the CDC may recommend an additional dose of a pneumonia vaccine based on what was previously administered to them. So for example, if the resident received a PCV15 vaccine 2 years ago, they're not considered up to date. So coding O0300A as 1 would be inaccurate coding and could be result in a deficiency under both MDS coding as well as the pneumococcal vaccinations.
I think the best practices you outline sound like a sure way to maintain compliance. Are there vaccine considerations our viewers need to think about for other vaccines or employees?
That is a great question. So you are required to assess and report on COVID-19 vaccines for both staff and residents. The residents in two places as NHSN and the MDS both include the COVID-19 vaccine status. Also, you are required to report RSV vaccines for residents into NHSN. However, these figures are not included in your quality measure reports. They are part of the quality reporting program, and you're evaluated based on the reporting being complete and not necessarily the highest percentage that you would be with the influenza and pneumonia vaccinations. Additionally, for employees, you must track their influenza vaccination status and report it annually to NHSN. Again, this is within the QRP program and not your quality measures. However, there is a regulation that is similar to the influenza and pneumonia vaccine regulation that requires you to assess the employee and residents' COVID-19 vaccination status, provide education, and administer the vaccine if they consent to it. Right now, things are slightly tricky with the COVID-19 vaccine because the federal government has narrowed down the eligibility to be individuals over 65 years of age or older, which likely includes most of your residents, but not your staff. So, however, if you're still required to report on staff COVID-19 vaccination status being up to date, and so it's a little tricky to understand what that up to date status is. So, right now, NHSN has not updated their up to date definition. So, we keep reporting on whether or not the employee received a COVID-19 vaccine within the 24-25 vaccine series. This adds even more uncertainty to the equation, and certain states are now issuing different guidance than the federal government, such as Illinois providers are looking at a different document that the government has posted that opens vaccine eligibility for COVID-19 to anyone 18 years of age or older, but that does not factor into your MDS quality measures or your quality reporting program definitions. So pay close attention to which definition you are coding and where you are coding it at. If you have any questions, please don't hesitate to reach out to us, and we can provide you with the current information on vaccinations and where you should be reporting and when. Before we end today's webcast, Sam, do you have anything you'd like to add?
I don't think so. You're the clinical expert, but thank you so much, Kelly, for all the time and effort you put into sharing this information. It's really helpful to have such a clear overview, and I appreciate all the guidance you've provided today.
Yeah, thanks, Sam, for joining me. We hope you found this webcast helpful and join us for the next one as we discuss falls. And not to give away any of the next webcast information, but there were some recent changes in this area that will likely impact your future quality measures. So we'll see you next time. Have a great day.